جديد توا. هذا زي ما
طبعا.
قلنا دكتور خلوصي بهجت تركي درماتولوجيست، وفي 1937 he published this article in a German dermatology journal titled on relapsing after ulcers of the mouth, eye, and genitalia caused by a virus. طبعا it is not a virus as we know today. Behcet disease is a systemic disease. It can affect many systems, mainly the skin, the joints, the eyes, the blood vessels, CNS, GIT, and even more systems. It is a chronic disease. Chronic means it is not curable, but طبعا should be treated. It starts usually in young age. The usual age of starting is around 20 years of age. It affects both sexes, males and females, and males have more severe disease than females. And as you later on, early diagnosis and treatment is very important to avoid serious complications in the eyes, blood vessels, and CNS. What causes Behcet disease? I will use a phrase of this earlier American Minister of Defense in the era of Bush at the beginning of this century, 2003. As you know, the United States attacked Iraq because, as they said, Saddam Hussein had weapons of mass destruction, and he was supplying terrorists with these weapons. Donald Rumsfeld was asked by a journalist what evidence he has that Saddam Hussein has these weapons. He said there are known knowns and there are known unknowns. Also in Behcet disease, we have known knowns and known unknowns. The known knowns are two, one geographical and one genetic. The geographical ones is that Behcet disease occurs in an area between China and the Mediterranean Sea. This is called the Silk Road. This was used to transport silk from China through the Middle East via the Mediterranean Sea to Europe and to North Africa. And it is a fact that the disease is mainly common in these countries. In the rest of the world, it is much less common or even rare. Why it is like this, we don't know. But and there are countries with different cultures: China, Japan, Middle East, Arabic countries, and so on, and the South European countries. The other known is the association between HLA-B55 and the disease. In 1980, a Japanese ophthalmologist, his name was Shigeaki Ono, he published in the American Journal of Ophthalmology an article saying that Behcet disease is associated with HLA-B5. At that time, only B5 was known. Later on, two sub-alleles of B5 were discovered, and they named them B51 and B52. But the B51 is the one which is associated with Behcet disease. This is, by the way, Shigeaki Ono. In meta-analysis of 52 studies dealing with B51 with almost 3,000 patients and more than 1,000 controls, it was found out that the Behcet patients or the 58% of them had the B51 allele. In the control group, it was just 18%, meaning that the B51 has a six-fold risk increase for Behcet disease. Okay, these were the two known knowns. Now I come to the known unknowns. We know that they are there, but we don't know what they are exactly. What we know that they are environmental factors. How we know this? This is the prevalence of Behcet disease in different countries. Just look to the red figures. The prevalence of Behcet disease in Turkey is between 80 and 370 per 100,000 population. The prevalence among Turkish people living in Berlin, Germany, I mean the second generation, is just 21, much less than their grandfathers or the grandparents in Turkey, and much more than the German natives. This means that these Turkish people have the same genes, but they are exposed to different environmental factors. That's why the prevalence is less. We guess that these environmental factors could be infections, air pollution, maybe smoking, maybe exposure to chemicals, which are used in agriculture, such as fertilizer and pesticides, maybe others we don't know exactly. Another indicator of this hypothesis is what Ono once published. He published that the prevalence in Japan is decreasing. In 1981, the prevalence was 14.5 per 100,000 population. 10 years later, became just 10.3. And 20 years later, it was almost the half of 1981. Possible causes for the decrease in the prevalence is the reduction in air pollution and the reduction in the rate of infections. This is what Ono think. But these are the known unknowns. Maybe there are unknown unknowns, we don't know. The future will show us this. Okay. The pathology of Behcet disease is the inflammation in the blood vessels, the vasculites. Behcet disease belongs to the vasculitides. Although the commonest manifestations, I mean the mucocutaneous lesions, do not generally manifest as vasculites. And the vasculites of Behcet disease is the one which affect arteries and veins, affect all types of vessels, not only arteries. And even more venous involvement of the large vessels. If the arteries are affected, we will have arterites, and these arterites will lead to building of aneurysms, which can rupture and lead to a catastrophe. Another interesting aspect of the disease is the pathergy, what we call pathergy. Pathergy is a special form of allergy. It represents hypersensitivity of the skin, or of actually all tissues, to mechanical irritation. For example, if you take a blood sample from the patient, or you inject IV drugs, the skin will react with pustules like this. And this pathergy reaction is used as a bedside test, and is even one criteria. If you want to perform this, and you should perform this pathergy test in a patient suspected to have Behcet, you take 1 cc normal saline and inject it with a thin needle intradermal. And then if the reaction is positive, the patient will have these pustules. The pathogen test was once well researched and well studied. It is quite specific to Behcet, but it is not pathognomonic because it can be found in other conditions like pyoderma gangrenosum, Sweet syndrome, FMF, leukemia, treatment with interferon, and even in Crohn's disease, it can be positive. And the strange thing that the pathogen test positivity is different in different countries. In Turkey and Japan, it is quite common, 60 to 70% of the patient have this pathogen test. In north of Europe and America, it is rare. And if you perform the test, you should wait 48 hours before you read it. Not after 24 hours, you can have false positive results. And what we found out is that immune suppression by drugs, immune suppressive treatment, does not affect the reaction, meaning that you can perform it even in treated patients. And what makes things more confusing is that the reaction can convert spontaneously from positive to negative, or from negative to positive. And this pathogen reaction has no correlation to any systemic feature of the disease or HLA-B51. Coming to the clinical presentation, which is variable. Some presentations are benign, some are less benign, and some are malignant. The benign one are the mucocutaneous lesions, which is seen in all patients. The most common one is oral ulcers, like here. You find them on the lips or on the tongue. Actually, all patients will have these ulcers. They are painful and bother the patient. They last around 1 week, and they are recurrent. After 1 week, they heal spontaneously, but recur after a few weeks or maximal months. The genital ulcers are less common. They are only found in 50% of the patients. In males, they are found in the scrotum or on the penis. In females, on the labia. That's why you should send the female patient to a gynecologist looking for these ulcers. Another mucocutaneous manifestations of the disease is erythema nodosum, pseudofolliculitis, or acne-like lesions. The moderate manifestation of Behcet disease is the articular involvement. And these are the patients which come primarily to us rheumatologists. It causes arthritis with all its manifestations, pain and swelling and hotness and limitation of movement. It affects 50% of the patients. Every second patient will have arthritis during the course of his disease. It is usually mono to oligoarticular, and the most affected joints are the joints of the lower limbs, the knees or the ankles. The arthritis of Behcet disease, this is for the daily routine important to know, is a productive. Productive means it produces a big amount of fusion, as you see in this knee. And the good news is that it is not destructive, does not lead to deformity. Okay, I come to the malignant manifestations of Behcet disease, which there are three: the ocular manifestations, the CNS manifestation, and the vascular manifestations. Behcet cause inflammation in all, or can cause inflammation in all layers of the eye in around 50% of the patients. Every second patient will have his ocular involvement. It can cause inflammation in the anterior chamber, causing uveitis, and anterior or posterior chamber, causing posterior uveitis. It can affect the optic nerve, or it can affect the retinal vessels, causing vasculitis and occlusion of the veins or arteries. For your daily routine, Behcet causes usually posterior uveitis or pan-uveitis. It does not cause isolated anterior uveitis. Why I'm saying this? Because these patients will attend primarily the ophthalmologist, and the ophthalmologist will refer the patient to you, asking whether he has rheumatic disease. If it is isolated anterior uveitis, it is unlikely to be Behcet. It would be maybe, or rather, spondyloarthritis. Another interesting aspect of Behcet disease in the eyes is the so-called hypopyon. Hypopyon is collection of sterile pus in the anterior chamber. The ophthalmologist will see it. It will look like this triangle. It is very characteristic of Behcet. If the ophthalmologist see this hypopyon, the diagnosis is quite sure. But it is not common in Behcet. Less than 10% of the patient have it. The ocular involvement often lead to complications because it is recurrent. The patient will have his attacks of uveitis every few weeks or few months, and every attack of inflammation will lead with scarring, and these scarring are called synechia. And the repeated synechia will lead to decrease in the visual acuity and building of glaucoma. If it is not early diagnosed and treated, it will lead to loss of visual acuity and blindness. Blindness is these days the most common cause. Behcet disease is the most common cause of blindness in many countries in the Mediterranean area. And complication can also occur due to treatment, because these patients, when they have their attack of uveitis, are treated with high dose of corticosteroids, and corticosteroids will lead to cataract formation and infections. This is one of our patients. He became blind when he was 23 years old due to late treatment or not treatment. You see here how he is guided by his brother into our clinic. This patient became also blind due to complication of the treatment. He was operated and then treated with corticosteroids, and he developed the infection, and you see the result of the treatment. Okay, the next malignant phase of Behcet disease is the CNS involvement, which is called neurobehcet. Neurobehcet affects only 10% of the patients, not very common, and it occurs more in males than females. وطبعا it can attack many lesions. It can cause many lesions in the brain, but the clinical presentation, depend on the site of lesion. Neurobehcet early diagnosis is very important because the neurological deficits are often irreversible. Neurobehcet was not properly studied till some years back, when during one of the Behcet congresses, every 2 years there is medical congress only for Behcet disease, where experts from all over the world meet and discuss Behcet. But during this one congress around 15 years back, 52 experts from 22 countries came together. The coordinator were Adnan al-Rajai and Sima Karla from, these are neurologists from London, and they started the project to develop consensus recommendations which might be helpful for the neurologists and other clinicians. It is a long story. I don't have time now to tell the whole story. This is, by the way, Adnan Araj with some of the experts. And their recommendations were published in the Journal of Neurology, 2013. These recommendations were regarding classification of Behcet disease, diagnosis of Behcet, classification of neuro-Behcet, diagnosis and management. We classify neuro-Behcet in 3 different types: central, peripheral, or mixed. And the central can be parenchymal or non-parenchymal. In parenchymal neuro-Behcet, there is inflammation in the brain tissue in certain predilection areas, mainly the brain stem, cranial nerves, and spinal cord, beside the optic nerve. The non-parenchymal neuro-Behcet is caused by vascular involvement, the veins or the arteries of the brain. Neuro-Behcet can also cause peripheral neuropathy and mononeuritis multiplex. Mixed neuro-Behcet means parenchymal and non-parenchymal. This is now more neurology. It is pity that no neurologists are among us. I'll show you one picture from our patients, which presented with 7th nerve palsy, as you see here. And it doesn't surprise because the nucleus of the 7th nerve lies in the pons. The brainstem and pons are predilection sites for neuro-Behcet. And these recommendations distinguish between definite neuro-Behcet and probable neuro-Behcet. Definite neuro-Behcet is if the patient has enough criteria for Behcet and he presents with neurological manifestations well known to be caused by neuro-Behcet, وطبعا supported by imaging and CSF examination. No better explanation for the neurological findings can be found. The probable neuro-Behcet is when the patient has criteria for Behcet disease, but present with features not known to be caused by neuro-Behcet, or vice العكس. يعني he has criteria but present with the neurological deficit not known to be caused by Behcet. In neuro-Behcet, the lumbar puncture is mandatory. You have to examine the CSF, which is altered. We will have high cell count and high protein. Glucose is normal. And you have always to check for oligoclonal bands. You will find none. If you find some oligoclonal bands, this will more direct to multiple sclerosis. And very specific for Behcet, for the neuro-Behcet, the parenchymal neuro-Behcet, the interleukin 6 is high, is raised. Not in the serum, but in the CSF, The imaging of choice for neurobehcet is the MRI. You will see lesions, well, the neuroradiologist will see lesions in the brainstem, thalamus, and basal ganglia. Here are the predilection sites of MRI, of neurobehcet in the MRI. Okay, the third malignant phase of Behcet is the vascular involvement, which is found in 10 to 30% of the patients. As mentioned before, arteries and veins can be affected, large and small vessels. If the veins are affected, they will have inflammation. This is called phlebites, and on the top of this phlebites, thrombosis will occur. If the arteries are affected, they will have arterites with ischemia in that part of the tissue affected, and this ischemia will lead to building of aneurysms, which can rupture anytime. وطبعا the clinical presentation of vasculitis depends on the type, size, and site of the involved vessel. I will show you some picture from our patients. This patient has phlebites in the popliteal vein, presented with DVT. You see here the swelling in the leg. This another patient had thrombosis in the iliac vein and superficial thrombophlebites. You see here the inflamed vein. You even can palpate this vein. These patients, all these patients, all these pictures you see are from our own patients. No one is from the internet. Had involvement of the inferior vena cava with building of aneurysm in the inferior vena cava and occlusion of the inferior vena cava. And this has led to building of collaterals. You see the dilated veins here due to occlusion of the inferior vena cava. And they look similar to caput medusae in portal hypertension. Maybe you have seen more caput medusae than these veins. But caput medusae are in the center. These are more lateral. Okay. This patient had involvement of the superior vena cava, which became obstructed due to building of thrombus. You see here the congestion of the superior vena cava, and this is his angio. This is the left one, the patent one, the not affected one, and the right one is not there because it is completely occluded. This is another sad story. You know, behind every picture, there is a story. This patient was a young one, maybe 24, 25 years. He presented first to the respiratory department because of hemoptysis. And then it was found out he had Behcet, and he was referred to us. And when we have his X-ray, we saw these round lesions. And this is his angio. You see these round lesions. These are aneurysms of the pulmonary artery. And unfortunately, he died, he expired because of rupture of this aneurysm. Okay, I come to the criteria of Behcet disease. We clinicians and students love criteria. No one disease in medicine has too much criteria like Behcet disease. You can count here 14 different criteria. In the 90s of last century, the beginning of this century, the most used criteria was the ISG criteria from 1990. These criteria say that a patient should have recurrent oral ulcers plus 2 of the following: recurrent genital ulcers, eye lesions, skin lesions, and pathogen test. These criteria are very specific or highly specific, but they are not sensitive. Why? Because without oral ulcers, you cannot make a diagnosis of Behcet disease. And we know that some cases start without oral ulcers. This is called the non-aphthous beginning. And this non-aphthous beginning of Behcet disease, according to different studies and different series, occur in 13.5 to 40% of the cases. And this pre-aphthous phase can last up to 3.5 years in males and 7.2 years in females. But that's why during one of the Behcet congresses, an international team of 27 countries came together under the coordination of Faruddin Davachi from Tehran, and they decided to validate these ISG criteria. They collected data between 2005 in March and June 2006. They collected in total 2,556 patients and more than 1,000 controls. We participated with 52 patients and 9 controls. And again, it is a long story. I don't have time to tell it, but the conclusion of this project was that the validation of this ISG criteria failed and the revision is necessary. And so the new ICBD criteria were born. This is, by the way, Faruddin Davachi. And these criteria were published 2013 in the Journal of European Academy of Dermatology and Venereal Disease. And these are the criteria. It is a score system. Ocular involvement, genital ulcers and oral ulcers score 2 points. Skin lesions, a part of oral and genital ulcers, meaning pseudofolliculitis or erythema nodosum, score 1 point. Neurological manifestation, 1 point. Vasculitis, 1 point. Pathogen test, 1 point. If the patient has more than 4 points, the diagnosis is quite sure. Okay, this was the presentation. Coming to the treatment. Treatment depends on the affected system. Is it the skin? Is it the eye? Is it the joint? Is it the CNS? It depends on the severity of the disease. How severe is it? How acute is it? And the chronicity. Chronic lesions, in general, can't be improving by treatment. That's why early treatment is mandatory. Here are the EULAR recommendations for the management of Behcet disease from 2018. I agree it is a very busy slide, confusing. I will make it easier for you. I summarize the drugs used. But actually, we have 4 groups of drugs which we use in Behcet. We have colchicine, which is indicated if you have mucocutaneous lesions, and all patients will have mucocutaneous lesions, meaning colchicine is always indicated. And it is also effective in articular involvement. 1 milligram daily colchicine. Corticosteroids are indicated in active disease at the beginning of the attack, because Behcet disease occurs in attacks, either local or systemic. Local, for example, cortisone gel for the mouth ulcer or for genital ulcers, or in articular involvement with big amount of fusion, you aspirate and inject corticosteroids, or systemic in other manifestations. Usually we start with high dose, 1 milligram prednisone daily. And then as soon as the patient improves, we taper the dose and try to keep him out of cortisone. The third group of drugs we use are immunosuppressants. We have MTX, azathioprine, and cyclophosphamide. Methotrexate is indicated and effective in articular involvement, the same dose like in rheumatoid arthritis. In ocular involvement, we give azathioprine for a long time, for years. If there is CNS or vascular involvement, cyclophosphamide is the immune suppressive drugs of choice. As long as the patient is controlled with these drugs, it's okay. If not, sometimes you are faced with therapy-resistant case. In this case, you give TNF blocker inhibitors. The most used TNF inhibitor is the adalimumab, 40 milligram every second week. And for the daily routine, some patients, as mentioned, present with DVT, but these patients do not need to be anticoagulated. They don't need heparin or warfarin. Why? Because the thrombi in Behcet disease are attached to the vessel wall. They don't emboli. And if there is DVT, means there is vasculitis. And if the patient has venous involvement, he also can have arterial involvement with building of aneurysms, which are asymptomatic. But it will increase the possibility of rupture. Recently means a few years back, a new drug is approved. This is called Apremilast. Apremilast Otezla is since 2020 approved in many European countries for oral ulcers which cannot be controlled with colchicine and local cortisone. Here's the dose. You start with a small dose and you can increase up to 30 milligram twice daily. You might be surprised by this picture. I show it because Behcet disease is an inflammation, and inflammation, the word inflammation originates from flame, like in Arabic. Iltihab arises from lahab, and this is fire. If the firefighters come early and put out the fire, most of the things or most of the tissue will be saved. If they come late, I mean, if the treatment is initiated late, the fire will eat everything. And if you call the firefighters, they will not be beneficial if it's burned out. But that's why early diagnosis and early treatment is very important to avoid blindness or loss of visual acuity, to avoid neurological deficit and building of aneurysm with rupture. This is my last slide, my take-home message to you and especially to the young colleagues. Behcet disease starts usually in young age. You should consider the possibility of diagnosis in young. If you have old patient, with old I mean older than 40, it will be very unlikely to be Behcet. Behcet always starts in young age. The presentation is variable. Patient can come with skin lesions, with ocular problem, joint problem, and so on. I didn't mention gastrointestinal involvement because it is very rare in our area. It is quite common in Japan, but I myself, I never saw it. But in our area, it is absolute rare. The gastrointestinal involvements would manifest as colitis. The diagnosis of Behcet disease is always clinical. There is no one test which confirms or excludes Behcet. You only can make a diagnosis with good history, good examination, and the criteria are helpful. Always think damage is often irreversible, and in doubt, refer the patient to experienced ophthalmologist or gastroenterologist. Thank you for your attention.
السلام عليكم ورحمة الله وبركاته. مساء الخير للجميع. بداية سنة موفقة إن شاء الله لجمعيتنا، الجمعية الليبية للروماتيزم. نشكر بروفيسور دكتور خالد المنتصر على المحاضرة القيمة على مرض بهجت في الكبار. الآن إن شاء الله نبدو جزء الخاص بالأطفال. نحب نشكر الأستاذ استشارية الدكتورة سعاد حشاد على إتاحة الفرصة لي بالتعريف بمرض البهجت للأطفال. نبدو محاضرتنا إن شاء الله pediatric Behcet disease in practice with case presentation. Our patient, 12-year-old boy, presented at December 2022 with a history of 3-month duration, suffering from severe headache, blurred vision, low-grade fever, and behavioral changes. Initially, he managed as a case of sinusitis with oral antibiotic. His condition worsened and he developed prolonged abnormal movement with vomiting, high-grade fever. He admitted in Sleaton Hospital as a case managed as a case of meningitis. Temperature was 39.5 and neurological examination was normal, only bilateral papillary edema. He had high inflammatory marker. Echo done was normal. CT angio for aorta and main branches was normal. CT for paranasal sinus also was. MRV was done. Feeling defect were observed in left sigmoidal transverse and superior sagittal sinuses. Diagnosed as sinus vein thrombosis secondary to meningitis. Treated by IV antibiotic, antiviral, and heparin infusion. His medical condition improved, discharged on oral warfarin, and he planned for further follow-up with ophthalmology, hematology, and neurology. A neurology follow-up, he followed by MRV at 3 months after presentation. He had same finding. After about 4 months, he had partial improvement, and about after 7 months, he had completely resolved his previously seen cerebral sinus. About his hematology follow-up, he screened for thromboembolic condition. He had protein C and protein S deficiency, normal BTU, BTT, and INR on warfarin treatment. Ophthalmology follow-up was he had 1 year of remission and relapse on high-dose steroid orally, short courses, and local eye drop, steroid eye drop for short courses. First presentation for his binevitis was at December 2020. Always he had panuveitis in every ophthalmology examination, and his visual acuity affected mainly in right eye was counting finger. Transferred to us as a case of panuveitis for more evaluation and treatment. When he presented to us, was diagnosed as multiple Patient transferred to us for more evaluation and management as a case of panuveitis. Ophthalmology examination seen and was panuveitis in both eye. Evaluation was done about his investigations and ENA and ABL screen. HALA B51 also was sent. All of them was normal, and protein C and S still has protein C and S deficiency. When review his history, the patient was history of recurrent fever, diagnosed as recurrent tonsillitis, and tonsillectomy was done. He had 7-year-old, since 7-year-old, he has a recurrent oral ulcer. When review his sign and symptom on pediatric criteria for Behcet disease, the patient has recurrent oral ulcer, has ocular involvement, panuveitis both eye, and has neurological symptom, and has vascular sinus thrombosis. So, according to this pediatric criteria for Behcet disease, patient diagnosed as Behcet disease and treated on mycophenolate mofetil tablet, 100 milligram per surface area. His follow-up on this on mycophenolate mofetil, the patient has improvement on his ophthalmology examination and his complaint of oral ulcer. About ophthalmology examination, in first year of follow-up, he has a flare only once. 2 year on treatment, no more a flare. He is remission now on mycophenolate mofetil. About his oral ulcer, decrease in frequency and duration in first and second year. Now he is only short duration for and prolonged period of remission on treatment. Not on systemic steroid and not on local steroid eye drops. Behcet disease in pediatric is a systemic vasculitis. Exact cause remain unknown and believed to be autoimmune reaction triggered by environmental factor in genetically susceptible individual. High incidence in communities living along historical Silk Road. Usually developed in young adulthood. It is reported that about 15 to 20% of all Behcet patients develop Behcet in childhood. Pediatric Behcet differ from adult Behcet in gastrointestinal symptom involvement, neurological finding, and arthralgia. Positive family history are common in children. Genital lesion and vascular lesion are more common in adult patients. Better disease outcome with lower severity score and activity index has been reported in children. Pediatric Behcet described as pediatric Behcet when disease started and diagnosed in childhood. Juvenile Behcet referred to cases was started in childhood before 16 and completed in adulthood. A clinical finding of pediatric Behcet, mucocutaneous lesion, oral ulcer, painful, non-scarring, 96 to 800% occur many years before the diagnosis has been established. Genital ulcer heal with scarring. Mucoskeletal involvement, 20 to 40% early finding, self-limited and heal without deformity. Oligoarticular or polyarticular pattern and sacroiliitis. Sacroiliac joint involvement with enthesitis. Eye involvement 14.1 to 66.2% within 2 to 3 years after diagnosis, but can occur anytime, less common than adult, and had more severe course. Bilateral posterior uveitis is most typical pattern. Neurological involvement 3.6 to 59.6. Non-parenchymal vascular forum is more common in children. Cerebral venous thrombosis and pseudotumor cerebri. Gastrointestinal involvement 4.8 and 56.5% 4 to 4.5 to 6 years after the onset of oral ulcer. Diagnosis is challenging. Absence of specific diagnostic test and long time interval in pediatric Behcet from first finding of disease to full-blown of symptom of Behcet disease. Definition and classification criteria. Having valid and universally accepted criteria with high performance is very important in pediatric Behcet disease to help us to determine patient for our study, and also possible to compare the result of different study and conduct multi-center, multinational study efficiently with universally accepted criteria set. Guide us through our clinical practice and helpful for disease diagnosis, especially for physicians who are not expert in Behcet disease in pediatric. What are characteristics of diagnostic criteria sets for Behcet, and what are the factors restricting the universal use of or acceptance of these criteria? Let us to start with the first criteria, which is the International Study Group criteria for pediatric Behcet disease, presented at 1990 and 1992. According to this criteria, oral ulcer is mandatory. In addition to, patient should have two of the following four features to be classified as having Behcet disease in pediatric: genital ulcer, ocular manifestation, and positive Behcet test. This criteria is low sensitive because oral ulcer was considered to be obligatory as a manifestation of pediatric Behcet disease and don't allow for variation in symptoms of Behcet disease. We are aware that there are pediatric Behcet disease cases without oral ulcer. Thus, inclusion of oral ulcer as a mandatory criteria was probably one of the factors limiting performance of this international study group criteria. The second one is international criteria for Behcet disease. Was created in 2006 and revised in 2010. The patient gets 2 points for each genital ulcer and ocular manifestation, and 1 point for each oral ulcer, skin manifestation, and vascular manifestation, and positive Behcet test. Patient is classified as having Behcet disease if she or he gets 3 points or more. Include a wide variety of symptoms such as vascular manifestation, skin lesion, and neurological manifestation can be used with or without conduction of Behcet test. Improved sensitivity over international study group criteria while still maintaining responsible specificity. Third criteria is pediatric Behcet criteria, published in 2015. Pediatric Behcet criteria set all symptom category have the same weight. Behcet disease Behcet test is not included. Oral ulcer is not mandatory criteria. For classifying a patient as having Behcet disease, the patient should have 3 or more of the following criteria: oral ulcer more or equal or more to 3 attacks per year, genital ulcer typically with scars, skin manifestation, neurological manifestation, oral manifestation, and vascular manifestation. This criteria is very specific, and giving higher value of oral after item could be improved the performance of criteria set. This may be one of the reasons for revised international criteria having higher sensitivity than pediatric criteria. Studies done with more than 30 Behcet disease patient testing for performance of Behcet diagnostic criteria and classification, it's important to emphasize that no diagnostic classification criteria have 100% sensitivity and specificity. There are few pediatric studies testing the performance of Behcet diagnostic classification criteria. Revised international criteria has highest sensitivity, and international study group had remains as a most specific criteria set. Factors restricting the universal use of diagnostic classification criteria for pediatric Behcet disease. Disease phenotype differ among different age group, especially between children and adult. Frequency of organ manifestation different among male and female. Disease characteristic differ according to ethnicity and country of residence. Clinical practice for pediatric Behcet differ among different country or even different healthcare center. After all, the gold standard for diagnosis in diagnosis of Behcet disease is expert opinion. We had, in our patient had oral ulcer, thrombosis, and protein C and S deficiency. There is a controversy between association of Behcet disease and protein C and S deficiency. First study was done in 2011 in China. Interestingly, the level of protein C and factor VIII clotting activity were lower in the major oral ulcer group than in minor oral ulcer group. These data suggesting that the level of protein C and factor VIII clotting activity might be correlated with the severity of recurrent oral ulcer. There is many studies still study correlation between activated protein C resistant in Behcet disease. Some of them show without statistical significance, and another one show there is significant statistical significant correlation between Behcet disease and protein C and deficiency. Behcet disease is a rare but potentially serious condition with diverse manifestation. Cavernous sinus thrombosis, a rare but critical complication of Behcet disease, can cause vision problem, facial pain, and neurological deficit. Early diagnosis and prompt treatment of Behcet disease with steroid and immunosuppressive and anticoagulant are critical for preventing irreversible neurological damage and improve outcome. Close follow-up is essential for managing Behcet disease and its complication in long term. Larger multinational pediatric Behcet disease cohort with adequate control group are required to compare the performance of different criteria set in children and to improve the performance of existing pediatric Behcet criteria. Thank you.